All right, hello, my name is Joe. I'm going to be your student nurse for today. I'm going to close the curtains for privacy and security. I'm going to wash my hands. I'm going to put on my gloves.
Is there a
I'm
third
going to
paper?
verify your name and date of birth. You tell me your name and date of birth.
Put them all together so
I'm going
everybody
to check and
will
make sure I have all the equipment I need for my assessment, and I do. I'm going to check the doctor's orders. I'm going to verify whether you have any allergies. You do not. I'm going to go ahead and ask you who the president is. You tell me who the president is. I'm going to ask you who you are. You tell me you're in a hospital. Patient is alert and oriented ×3. Patient appears in no acute distress. Patient appears relaxed and cooperative. Posture is erect. Patient's weight appears within normal limits. The skin tone is even and consistent. Hold on. Skin tone is even and consistent. I just got lost. Oh my gosh. You guys are making me nervous. Okay. Let me get my bearings. I'm going back. Okay. Skin tone is even and consistent. Posture is erect. No acute distress. No, that's for anterior. That's for when we do the anterior. Okay, then we move on to, we pass the general survey, we move on to the hair. No thinning of the hair. Patient has all of his hair. We're going to go ahead and palpate. For any masses or tenderness, there's no masses, no tenderness. Head is normal cephalic. We're going to go ahead and palpate the frontal sinuses. Okay, no pain, no tenderness. Maxillary sinuses, no pain, no tenderness. We're going to assess the temporal artery pulse. Temporal artery pulse is normal 2+. We're going to assess the jaw for clicking and popping. Open your mouth. No clicking, no popping. Close really tight. Cranial nerve 5 is intact. I'm going to ask you to open your eyes really wide. Close them really tight.
Terry,
Puff
on
out your
those
cheeks,
three
smile, frown.
times, put Kathy's class on it.
Cranial nerve
Because she has a
7 is
different
intact.
sign than
We're
she
going to ask you to lift your head up, put your head down, turn your head around, circumduct. We're going to ask you to push against my hand. Okay, push against my hand, shrug your shoulders. Okay, cranial nerve 11 is intact. We're going to move forward to the neck and shoulders. Neck and shoulders appear equal and bilateral symmetrically. We're going to look for any pulsations, any masses. There are no pulsations, no masses, no masses or tenderness when we palpate. We're going to palpate the trachea. Trachea appears midline. We're going to assess the thyroid now. Dislodge with the right hand and palpate with the left. Please swallow, no difficulty swallowing. And we are going to assess the carotid pulse. Carotid pulse is normal 2+. And from there, we're going to assess the lymph nodes. Preauricular, postauricular, submandibular, submental, supraclavicular, occipital, no pain or tenderness or masses felt. From there, we are going to move on to the mouth. With our pen light, we're going to look inside. Oral mucosa is intact. Palate is pink and moist. All teeth are white and accounted for. Tongue is pink and moist. Lips are pink and moist. Please stick out your tongue and say ah. We're testing the gag reflex. Uvula is present in midline and moving. Cranial nerves 9 and 10 are intact. Please stick out your tongue. Left, right, up, down. Cranial nerve 12 is intact. Then we move on to the nose. Nose appears symmetrical and midline. We're going to look inside the nose. We're looking for any lesions, any septal deviation, any obstructions, and we see none. So we're going to test the patency. I'm going to close one nostril, ask the patient to breathe in. They do. Opposite nostril. Breathe in. They do. Okay, airway, nose is open and patent. And we're going to do the nose test, the olfactory test. Please close your eyes. Get my little alcohol swab. What do you smell? Okay, I smell alcohol. Cranial nerve 1 is intact. We move from the nose to the ears. We inspect the ears first. Make sure there's no obstructions. Ears are symmetrical bilaterally. We're going to go ahead and palpate for any pain or tenderness. No pain, no tenderness. Then we're going to do the whisper test. 1, 2, 3. The patient repeats. 1, 2, 3. We do the other side. Then we do the Weber-Rhine. We take our tuning fork, hit it, place it on top of the head. Do you feel the vibrations in both ears? Yes, I do. Perfect. Again, I'm going to hit it again on my hand, put it on the mastoid bone behind the ear. Tell me when the vibration stops. Okay, it stops. Do you hear this? Yes, I do. You repeat it for the other side. Again, cranial nerve 8 is intact. Then we move on to the eyes. We grab our Jaeger card. Hold this out in front of you, please. Can you read the bottom line? LTFPH. Okay, 14 out of 14 on the Jaeger. Tell me what color this is. Red. And this color, green. Perfect. I'm going to go ahead and measure the pupil size. Pupil size is 3 millimeters. And we say that cranial nerve 2 is intact. Then we do the diagnostic test. Follow my finger.
What are they making at your house? Wheel?
Okay, cranial nerves 3, 4, and 6 are intact. Then we're gonna test for Perla. We have our pen light again. Okay. Perfect. Okay, now follow my finger. Alright, pupils are equal, round, and reactive to light with accommodation. Then we move down to the precordium. We assess the precordium for any pulsations, thrills, or heaves. We see none present. We're going to auscultate the apical pulse with our stethoscope, the bell of our stethoscope. We go on to like the left fifth intercostal space, midclavicular, with the bell. Okay, we listen. We hear soft, gentle tapping. Then we assess the 5 cardiac areas with the diaphragm of our stethoscope. So then we have the right second intercostal space is the aortic. Left second intercostal space is the pulmonic. Third left intercostal space is Erb's point. Fourth left intercostal space is the tricuspid. And then the fifth intercostal space left midclavicular is the mitral. Then we ask the patient to sit up and lean forward. We're going to assess for murmurs with the diaphragm of our stethoscope. Ask the patient to breathe regularly. Move our stethoscope around the areas of the heart. No murmurs present, no heart rhythm. Then we move from the precordium and the heart sounds, we move to the abdomen. We drape the patient from the waist down, expose their abdomen. We're inspecting with our pen light. We notice that the abdomen is flat and contour, skin is even and consistent with genetic background. Ask the patient to take a deep breath and hold for a second. We notice the aortic pulse, there's no visible peristalsis, and the abdomen is symmetrical bilaterally. The umbilicus is midline and inverted. So from there, we're going to move on to auscultation, again with our stethoscope, and we're going to listen with the diaphragm. So the right lower quadrant, there's normal bowel sounds. Right upper quadrant, we hear normal bowel sounds. Left upper quadrant, we hear normal bowel sounds. Left lower quadrant, we hear normal bowel sounds. Okay, now we're going to percuss and pretend the umbilicus is here. Okay, tympani, dull, tympani. Now we're going to do light palpation. Right lower quadrant, any pain or any tenderness? No. Right upper quadrant, any pain or any tenderness? No. Left upper quadrant, any pain, any tenderness? No. Left lower quadrant, any pain, any tenderness. One thing I forgot, when we're doing the auscultation of the bowel sounds, we have to do the arteries. So we go back, aortic artery where we saw the pulsation, we hear muffled heart sounds.
With the bell.
We use the bell. And then doesn't matter which one you do, but you can go to the left, you hear the left renal artery. You don't have to say you hear anything specific, just verbalize it. Left renal artery, right renal artery, right iliac artery, left iliac artery, and then the femoral arteries are normally in the inguinal area, so we'd say left femoral artery, right femoral artery. So we've inspected, we have auscultated, we've percussed, and we've done light palpation. Now we move on to the anterior thorax. We're going to inspect, we're going to pretend this is exposed, okay, or we can expose it a little bit. Inspect the anterior thorax for the respirations. Respirations appear non-labored. Skin tone is even and consistent. There's no signs of pallor or cyanosis. We're going to go ahead and assess the anterior chest expansion. Please breathe in and out. Okay, anterior chest expansion is equal and symmetrical bilaterally. We're gonna palpate for any pain or tenderness. There's no pain, no tenderness. Then we're gonna auscultate the lung fields with our stethoscope. Okay, here we have vesicular, vesicular, bronchovesicular, 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 vesicular, and vesicular. Okay, now we move on to our posterior dummy. Okay, so we're on the posterior. We notice that the configuration of the posterior back is elliptical. Now we're going to note the skin. Skin tone is even and consistent, no signs of cyanosis or pallor. Then we're going to palpate the posterior chest expansion. So we begin, we hold, patient breathes in and out, patient breathes in and out. So we have equal bilateral chest expansion posteriorly. And we also palpate for any pain or tenderness. We feel no pain, no tenderness. The patient tells us. So then we press.
There's a psychiatric term for that. No, flight of ideas. Flights of ideas. When a person is a psychiatric
She's
term.
probably not going to be too picky when you get there, but that's about how it goes. And you're also going to percuss the CVA, which is the costovertebral angle, which you find the 12th rib, about where the kidney is. And you're going to ask the patient if they feel any pain or tenderness when you bump your hand. Huh?
Both of them, I think it's both.
So then, okay, any pain or tenderness? No. Okay, then we move to the other side. Any pain or tenderness? No. Perfect. And then we auscultate the lung fields. So then we're auscultating the lung field with our stethoscope. Vesicular, vesicular, bronchovesicular, 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 vesicular, 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 normal breath sounds, and on the percussion, you want to make sure that you know that you hear normal resonance. So now from the posterior thorax, we move to the upper extremities. I did. Yeah, that was the first, that was like the second thing I did after inspection.
Yeah, I saw that.
No, it's okay. Then we move on to the extremities. You want to look at both of your extremities. Although you only have to work with one, you look at both. Okay, extremities appear equal and symmetrical bilaterally. Skin tone is even and consistent. The hair distribution is even and consistent. If you want to hit the bold first, you go ahead and do the radial pulse. Okay, the radial pulse is normal and 2+. And we assess the cap refills. Okay, cap refill is less than 3 seconds. Then you want to assess the range of motion and strength of the arm. So you ask the patients to elevate their shoulder, depress their shoulder. Then you can ask them to flex, extend, supinate, pronate, inversion, eversion. Then they want to abduct and adduct. Abduct, adduct, and they want to circumduct.
It's the other way around. Add is
Yeah.
adding, ab is out.
Yeah.
Mhm.
I
So you said it the
adduct
other way.
And abduct.
You said it the opposite way.
Okay, I'm sorry.
Adduct is the body.
Yeah, abduct is away, because that's like to abduct a child, is to take it away. So, yeah, so adduct and abduct. And then we did the circumduction. And from there, we can say that the muscle strength and range of motion.
He
Yeah,
did it.
I did
Supination and
supinate
pronation.
So then we note that the muscle strength and range of motion is graded at a +5. Then we move to our lower extremities. We note that our lower extremities appear equal and bilateral. Hair distribution is equal and bilateral. For the lower extremities, she only mentions to do the flexion and extension. So if you want to tell them to flex their knee or their upper leg, tell them to lift their knee to their abdomen. He does, that's flexion. Extension. If you want to tell them to extend their toes, they extend, and they flex. And then we assess the popliteal pulse, which is about here. If you want to say the popliteal pulse is absent, you can't feel anything, that's fine. I think a lot of people are doing that, but I'm just going to say normal +2.
Because you can feel it.
You can feel it, yeah, you can feel it. And then the posterior tibial
No,
pulse
and the
is
Vatican,
normal
it's like-
+2. And then dorsalis keys is normal +2. Then while you're down here, you want to assess for pre-tibial edema. So you can touch the skin for any signs of edema. You see no signs of edema, then you want to check for like temperature. If it's really hot, that's normally a sign of edema. But the skin just feels warm to touch. So that pretty much concludes the lower extremities, and of course you want to grade the range of motion and the muscular strength for the lower extremities is equal and bilateral symmetrically, and it's also a +5. So then when you get onto the neuro part, you want to do the whisk test, which pretend you have like a cotton swab or something. Ask them if they can feel it when you rub it on their face.
Do they close their eyes?
I don't think they have to. I mean, you just ask them if they can feel it, because you're not asking if they can smell anything. So you ask them if they can feel it. They say yes. Okay. Okay. Yeah. So you ask them to close their eyes, and then you touch their face. I guess, yeah, because if they see you doing it, then they're going to tell you. So then for the stereognosis test, that's where you put an object in your hand. So whatever, say I have a pair of scissors and I put it in his hand, he closes his eyes, closes his hand around the object, he says, I feel a pair of scissors. Then for the anesthesia test, you're gonna draw like a letter or shape on their hand, something easy that, you know, whatever. If you wanna draw a circle, they say, okay, you drew a circle. And then for the 2-point discrimination test, you wanna touch them at 2 points like simultaneously. So if you wanna touch them on the left hand and the right shoulder, and then you ask the patient again with the eyes closed, where am I touching you? Okay, he says my right shoulder, my left hand, and then
Does it have to be the same point on both sides? Okay, it could be any
it's 2 points, right?
Okay.
They have to identify. And then for the Babinski test, you normally use the tool that we use for the deep tendon reflex. We'll just pretend that I have it in my hand. We go up and follow the curve of the foot. And if the toes curl, that's normal. So they have a negative Babinski. Because if it's positive, then they normally flare out. From there, we can do the deep tendon reflexes. If you want to test the patellar, that's where you put the arm under the knee like this, and you want to use the tool, which we don't have. You hit it right here. The knee should jerk. So then you say,
Since they're laying down, we do
yeah,
that.
for the deep tendon reflex, they have a normal +5, because you have to do at least 3. So then if you want to do like the brachioradialis, which is here, you want to hold the arm and you tap it, the finger should curl. And then if you do the bicep, you're going to hold the arm like that, and like you want to hit your thumb actually, and then the arm should jump. Or you can do I like to do the tricep. I think it's easier. You could probably tell her how you're going to do it. If you lift the arm and you hit just below above the elbow, the arm should jerk. So then you have, you know, a normal +5 deep tendon reflex test. So then from there, you're going to test the gait and the Romberg. So when you're going to verbalize asking your patient to stand up and walk at least like 20 feet. And when they stand up and walk, you want to make sure that they have a normal sway, like a normal gait. If they start to stumble or, you know, they don't look fluid in their movement, then they have, you know, an abnormal gait. But if not, if they walk normal gait, Romberg test, they stand up, put their feet together, hands to their side, you ask them to close their eyes. If they start to sway or fall, then it's positive, that's bad. But if not, it's negative, and they're good. So I think that's it.